and Namaste. This is Dr. Srinidhi Chidambaram, and I'm very happy to see all of you at the COVID Care Series, FB Live series presented by Apollo Hospitals. The more we know the facts, the more we are aware it is much easier to deal with and cope with COVID-19. You can handle it calmly and confidently without any undue stress or anxiety. But that's easier said than done for most people because the COVID-19 pandemic is very frightening to all of us. And it is even more concerning for people who already have other diseases or pre-existing conditions. Many of them have diabetes, hypertension, or liver disease, or kidney disease, or cancers. And for them, it is even more difficult as they feel that they are more vulnerable, and they are more vulnerable. These are called non-communicable diseases and what we call as the comorbid conditions. Now, when these people get COVID, there is a lot of anxiety as to whether they will have a more severe course of disease, will they recover? And when they don't have, there is always so much fear as to whether they need to take more precautions. And can they go into the hospital during the pandemic for their own regular routine checkup and treatment? One such comorbid condition is liver disease. And to explain to us about managing COVID-19 with liver conditions and liver disorders, we have with us one of the most eminent gastroenterologists in the country and senior consultant, Apollo Hospitals, Kolkata, Dr. Mahesh Goenka. Dr. Mahesh Goenka has been practicing for over 33 years as a gastroenterologist, and he is the director in Institute of Gastro Sciences, Apollo Gleneagles Hospitals, Calcutta. He is the president of the Society of the Gastrointestinal Endoscopy of India. He's editor-in-chief of the Society Journal, the Journal of Digestive Endoscopy. He's also the member of an international committee of American Society of GI Endoscopy, and he has an MBBS from the Calcutta Medical College, Calcutta, India, a DM Gastroenterology from the PGI, Chandigarh, MD in Medicine, again from PGI, Chandigarh, and he's also a Fellow of the American College of Gastroenterology, Fellow of the American Gastroenterological Association, and the American Society of Gastrointestinal Endoscopy. His awards and achievements include the Cisco Pentax Oration for 2002, awarded by the Society of GI Endoscopy, Research Fellowship awarded by the Indian Institute for Study of the Liver, and the first position in MD Medicine from the PGI, Chandigarh. Hello, Dr. Goenka, and welcome to the FB Live series, the COVID Care series of Apollo Hospitals. We have these special episodes on non-communicable diseases so that we can assuage the fears and concerns of a large section of our population who already have all these conditions. So today we are going to talk about liver disease, and there are many, many questions, I'm sure, in the minds of our viewers. We will be taking questions after you speak to us. So there would be so many concerns as to, does the severity of liver disease also causes severe COVID? And how can you prevent COVID in people if you already have liver disease? And even about how these people can continue their current treatment and care at a hospital. Over to you, Dr. Goenka. And after you speak, we will also take some questions from our viewers.
Thank you, Dr. Srinidhi, and thank you for that very kind introduction. I think we have many webinars which are going on around, both for public as well as for doctors, about talking about COVID. But then I think it is also important, as you rightly said, that those who are not having COVID, they're also concerned that because of their comorbidities, what are the risks involved, and how do we prevent and tackle this in this present pandemic situation. So I have prepared a small presentation, which I will share with all of you, and then I'll be happy to answer all the questions. Please pardon me if you find some of the things on the slides a little more technical, but I'll try to make it as simple as possible. So, is my slide seen, Dr. Srinidhi?
No, not yet, Doctor.
give me a few seconds.
No problem. Yes, we can see it now, Doctor.
Yeah. Okay. So as we just discussed, and Dr. Srini rightly said that this COVID virus has been bothering us for now almost about 1.5 years. And rightly, we are all discussing about the mechanism, the morbidity, the mortality, the treatment associated with lung involvement, which is the primary site of involvement for COVID. But we must not forget that in the last 1 year or so, we have also realized that COVID is a systemic disease. And it's not only the lung which is involved, but virtually every organ of the body is involved, though the degree of involvement may be variable and the impact of this involvement may also be variable. So what I'll do in the next 8 to 10 minutes is to share to you with some of the knowledge which we have acquired in the last 1.5 years about liver disease in this COVID pandemic. So what I'm going to talk to you is basically to tell you about what are the liver dysfunction which can happen because of the COVID infection itself without any pre-existing liver disease. The second point will be what about somebody who already have a liver disease and what happens to him in the present COVID era. I'll briefly touch upon the liver transplantation issue and what should be our policy for vaccinating these individuals. So we should understand that when we talk of COVID-associated liver injury, that means we are talking of an individual who does not have a pre-existing liver disease. The COVID can affect them in a number of ways. And even the lay people now know that COVID virus, because of the spike protein, enters the liver and can directly cause the damage to the various organs, may it be lungs, intestine, or the liver. There is a cytokine release mechanism, there's immune abnormalities, there's abnormal coagulation, which has now been one of the important pathogenesis even for the lung disorder, that it is not the virus, it's abnormal coagulation in the lung blood vessels, which causes the problem to some extent. And then, of course, we talk about pre-existing liver disease, and we should not forget that some of the drugs which are used for the treatment of COVID lung disease can also cause liver injury. So we should understand that just like the lung has these ACE2 receptors, which makes the virus enter the lung, these receptors are present in the liver also, and in the various types of cells which are present in the liver. It can be present in the bile duct, it can be present in the liver itself, and in the blood vessels which are supplying the liver. So these red dots are all ACE2 receptors, which are the reason why these viruses enter the tissue. Now, so it has been found that almost 1/3, and the range is 14% to 53% of the people who do not have pre-existing liver disease, when they develop COVID, they can have abnormality in the liver function. And sometimes this can be very, very severe and can lead to what is known as acute liver failure with very high liver enzymes. It has also been found that those who have severe COVID lung infection are more likely to have liver dysfunction. So if you have severe lung disease, you're likely to have liver dysfunction. And there's some data which suggests that those who get liver dysfunction in presence of a lung COVID infection are more likely to die. So it is very important we should not underestimate the role of liver disorders in patients with COVID. Now, everybody now understands that there's a term called fatty liver, which we sometimes call it non-alcoholic fatty liver disease. And this is usually a part of metabolic syndrome. And when we say metabolic syndrome, this is a syndrome which contains diabetes, obesity, hypertension. And these people, because of this metabolic syndrome and association with diabetes and obesity, are more likely to have severe COVID. And so those who have existing fatty liver disease people should be aware that they are more likely to have COVID and more likely to have severe COVID. Now, those who have decompensated liver disease, means advanced liver disease, they have reduced immunity. They are immunocompromised. And so these patients are also more likely to have severe COVID disease. Now, this is a diagram which I just want you to understand that 3 societies in the globally, these are the 3 major societies which are collecting data and making a registry of those patients who have underlying chronic liver disease and developing COVID. And they have now about 1,500 patients registered in this registry, where they have found that pre-existing people are developing liver disease. And the liver disease can be either cirrhosis. Those who have their near and dear ones suffering from liver disease must have heard the term cirrhosis. So this can be either cirrhotic liver disease. It can be chronic liver disease without cirrhosis, like fatty liver disease I talked about. And there is a subgroup of liver transplant. So this registry has collected data on cirrhosis, non-cirrhotic people, as well as liver transplant. And this is the data which is collected from 35 countries, including India. And the data is interesting that while the etiology of cirrhosis can be different, alcohol, non-alcoholic hepatitis C, and so on, as many as 88% of them were hospitalized. So those who have cirrhosis and COVID require hospitalization in majority of cases, and the death rate was 31%. So look at the generally death rate of COVID, we know all in India is 1 to 2%. But when you talk of cirrhotic, the death rate can be as much as 31%. This is somewhat lower in chronic liver disease, non-cirrhotic, around 7%. Now, let's not get into the details of this slide, but what I wanted to say is that more severe the liver disease is, and this the last black color indicates severe liver disease, which in medical terms, say Child-Pugh C, you see that the death rate is much higher in them. So this is the death rate in non-cirrhotic, mild cirrhosis, moderate cirrhosis, and severe cirrhosis. So the higher the dysfunction, worse the liver disease, more likely that one would die because of COVID disease. So in general, the mortality in cirrhotic is 32% as compared to 8% in non-cirrhotic. It is related to severity of disease. Alcoholics are more likely to have worse prognosis, but we must realize that even in liver disease, patients presenting with COVID, majority die because of respiratory reasons, and only about 20%, 1 in 5, die because of liver disease directly. Now, what about the Asia Pacific data? Similar data from Asia Pacific that if you have liver disease without cirrhosis, severity is less. But if you have severe cirrhosis, decompensated cirrhosis, then the severity as well as the mortality is very high. Now, this is a very interesting chart, which I would like people to understand that this is talking about mortality in chronic liver disease without cirrhosis, early cirrhosis, late cirrhosis. If one is hospitalized, if you do not have cirrhosis, the mortality is 8% with any chronic liver disease. But if you have severe cirrhosis, the mortality is 54%, because that means if you are getting hospitalized with underlying liver disease and having COVID, 1 in 2 will die. Once you require admission in the ICU, this figure increases to almost 80%. And if you require ventilation, almost 90% of advanced cirrhosis will not survive. So this comorbidity is somewhat underplayed by everybody, and we must understand that cirrhotic people must avoid having COVID as much as possible. And there's a crosstalk between liver and lung. So it's the cirrhosis can cause a number of changes in the body. I'm not going into details of this, but ultimately they all can contribute to respiratory failure. So cirrhosis can increase, as I said, even cirrhotic patients, when they die, they have a fatal outcome. 4 out of 5 are because of respiratory failure. Only 1 out of 5 is because of cirrhosis per se. So when you have COVID-related acute liver failure, you have prolonged hospital stays, severe COVID illness, and a very high mortality. What about liver transplant? Now, the liver transplant, we must understand, have gone a little lower in the last 1 year for obvious reasons. Logistics are difficult. People are afraid. So presently, liver transplants are being done. We also did about 7 or 8 in the last 4 months, but they are done for semi-urgent or urgent indications only. So this slide shows the results of 151 liver transplant. While the hospitalization rate was the same, the need for going to the ICU and intervention was much higher in liver transplant group as compared to comparative cohort. And the death rate, surprisingly, was not higher in liver transplant patients. So they do not die, but they require good ICU care. I think I'm on the last 1 or 2 slides that we must not forget that a lot of medicines are being given to COVID patients, some without scientific basis, some with some scientific basis. But some of these drugs, in fact, majority of the drugs can cause liver disorders by themselves. And I've just circled 4 of them, which are commonly used. Azithromycin is a very commonly used antibiotics. I don't think we have enough evidence to use antibiotics on all patients with mild COVID, but this can by itself cause liver dysfunction. Remdesivir, now every person in the world have heard this name, and remdesivir is known to cause liver dysfunction. In fact, if the liver dysfunction is already there, then we usually do not start remdesivir. And if we start, we need to closely follow up these patients. Convalescent plasma, which was very rampant during the first phase of COVID, now we are not using it that much, can by itself transmit liver diseases. And this is the new drug which is now being marketed very steadily for COVID. This can also cause liver damage. So we should be very careful that while COVID can cause liver damage, the drugs which are used for COVID can also cause liver damage. So when you require interventions in liver diseases, like somebody is present with bleeding, you require an ERCP, treatment of SCC, we will still do it. But when the indication is not very hard, then one should avoid doing the endoscopy and intervention in these patients. Of course, it will depend on all the healthcare workers should be vaccinated, and they should not be the source of infection to the person coming to the endoscopy area, and we must follow the triaging and safe practice. Finally, what about vaccination? I think now vaccination is becoming universal, but I think patients with pre-existing liver disease, particularly those who have cirrhosis, those who have cancers, those who are waiting for liver transplant, or those who have already had liver transplant, must be prioritized by every organization to get a vaccine. Because as I told you in the last 8 to 10 minutes, that once if they develop COVID, their survival, their fatality risk is much higher. We must also realize that because of immunity being less, these people may not have protective response to vaccination as good as the general public. And so there may be a role for doing an antibody after giving the vaccination. We still do not have clarity whether the children with existing liver disease, we can give these vaccines safely. At this moment, we have 3 vaccines which are available in India, and mostly they are being used for the adult population. Thank you very much.
Thank you, Doctor.
So I am there for any questions.
Yeah, so basically, how can, supposing somebody has a liver condition, we said that, of course, they are more vulnerable to COVID-19, but how can they, on a practical basis, reduce their risk?
I think this is a very, very pertinent question. I would say that general precaution, which has to be done by anybody, should be done more vigorously by the people who have liver disease. So vaccination, maintaining safe distances, using masks, avoiding going in a crowd. I think all these has to be taken care, and then the liver disease people and their family should be extra cautious. As I said, among the liver disease, those who are having cirrhosis, those who have malignancies, those who are awaiting liver transplantation, those who already had liver transplantation, they must do everything to get vaccinated and get vaccinated as fast as possible. In fact, all the government organization and non-government organization also have prioritized these patients to get the vaccination. So I think avoiding COVID and looking at any symptom which can be because of the COVID. And I must here emphasize that the classical presentation of fever, cough, sore throat, respiratory distress may not always be present. So there may be some unusual presentation which you should look for. We just had yesterday a patient who presented up to us with diarrhea. And we just, as a routine, did a COVID test, and the patient turns out with COVID. The person does not have lung problems, does not have sore throat, no cough. So we must understand that not all patients with COVID represent the classical respiratory symptoms. So prevention and early diagnosis is the key.
So doctor, in somebody who does not have a liver disease, they happen to get infected with COVID-19. What are the liver manifestations that can happen?
First of all, I would like to start from my first slide, which I said that we must not forget that liver also have the same receptors which the lung has. These are called ACE2 receptors, angiotensin converting enzyme 2 receptors. So the lung alveoli, the lining of the lung has these receptors, so the virus goes and enters there. Similarly, the virus, even in a person who does not have a liver disease, can ultimately reach the liver and involve the liver cells also. So the person may have jaundice, the person may develop jaundice. It may be clinical jaundice or it may be picked up by the liver function test. We have patients who have developed acute liver failure in absence of any pre-existing disease. So I think a doctor who is treating would do a liver function test and follow it very, very carefully. Now, it has two implications, one on the disease itself and second on the choice of the drugs. As I said, if somebody has abnormal liver function tests, then we will not want to give them drugs like remdesivir. And there's a cutoff point of around 200, which has been decided by the various organizations that somebody who had a liver enzymes of more than 200, if you can avoid remdesivir, it's best to avoid. If you really need to do it, then you must monitor liver function tests on a daily basis.
Thank you, Doctor. What are the other gastrointestinal manifestations that can be perhaps sometimes the only presenting symptom in COVID-19?
I just told you one example of an individual who was admitted with a specific, and yesterday the patient was admitted just with diarrhea. But like in a hospital policy, we always, when the patient comes to us, we always do a COVID test, and we found that the patient is COVID positive, and the only manifestation was diarrhea. So I think the diarrhea is in fact one of the common manifestations of COVID. Now, when a person comes with respiratory symptoms and have diarrhea, then we don't care so much because we know the diagnosis is being done because the patient has respiratory symptoms. But one must not forget that there may be an isolated GI manifestation like diarrhea, which may be the only manifestation. It's not that it happens in majority of patients, but there may be a small minority which may have only GI symptoms. So diarrhea is one, nausea and vomiting is another, abdominal pain is third one. There may be mild pancreatitis, which can be also there. And of course, we talked about liver dysfunction. So all these are GI manifestations, and they're again related because GI system, intestines also have these receptors.
Regarding the diet and activity for a liver disease patient who has COVID-19, are there any special restrictions in their diet, or is there anything that they must be on complete rest, or does it depend on the severity of both conditions that they have?
So I would say that, so there are two components of the question. One is that any person who has pre-existing liver disease and is staying in this pandemic of COVID, there's nothing special they have to do. They should maintain their diet, their good diet, which should be nutritious, hygienic diet. That's all I have to say, that whatever they're doing, they must continue doing it. Here, there's one point which I would like to say, that there are lots of alternate medicines which are being given. And people who have a pre-existing liver disease take a lot of alternate medicines with an aim of preventing or reducing the severity of COVID infection. I must tell you, and I must tell you this, that some of them are hepatotoxic. I have 4 patients in the last 2 months whom we lost because they were taking one of these alternate medicines just as a prophylaxis for COVID. They have various combinations, and we don't know which causes what. But I would say that until there is a clear indication, please avoid this alternate medicine because they themselves can cause damage. And we had all these 4 individuals who died because of liver dysfunction caused by drug-induced hepatotoxicity. So I think a nutritious, hygienic diet is all you need to do. One should not experiment taking lots of preventive measures because some of them can be harmful to your liver.
I think that's a very, very important point that you made, Doctor, because I think this is even with people who normally follow or go to an allopathic doctor, when it comes to COVID, I think anything will do. So, everybody has their own concoctions or all kinds of preparations, and many people take it. So I'm so glad that you raised this point. I think that's a point to be emphasized, that please do not take any of these concoctions without checking with your doctor, especially if you have liver disease, because it could be hepatotoxic and worsen your liver condition. With that, the next question is about what about people who have already received a liver transplant? What happens when they contract COVID-19? Are they at particularly higher risk? And what is special in their treatment? Is there something different that is done for them?
I think it's an important question that liver transplant has now been done in many, many centers in the country. Before I answer that question, I must say the number of liver transplants done over the last 1 year has come down significantly because of various reasons. One is when you don't do the liver transplant for the non-urgent indications now, most of our liver transplants are for acute liver failure when we know that the patients are going to die if we don't do a liver transplant. The liver transplant, as you understand, is either a cadaver or diseased organ transplant where you get from the brain dead individual, or a life-related transplant. We are avoiding life-related transplant as of now because we are risking two individuals coming to the hospital, remaining in the hospital for a long time with a lot of contacts with various healthcare workers which is taking place. We are still doing cadaver transplant because I think cadavers are precious organs and we don't want to lose our organs. So with all precautions, we still do it. Now, coming to your specific question of liver transplant, I think the first few weeks or months after liver transplant are very, very risky because we give a lot of immunosuppressants to prevent liver transplant organ being rejected. So when you're giving so much of immunosuppression, there is a chance of getting a COVID, and the seriousness of COVID is more likely to happen in them. So if they have not received COVID vaccine before transplant, we always plan to give them a COVID vaccine. But there is no consensus as to when should they receive the COVID vaccine. In generally, we would want to give the COVID vaccine to the post-transplant people only after 2 to 3 months. Because that's the first 2 to 3 months when there's a lot of immunity issues. So after 2 to 3 months, when they are stabilized, you give them vaccine. But then actually the data do not show that these people are at more risk of mortality compared to non-liver transplant. So liver transplant after the initial 2 or 3 months are pretty safe in the COVID era. But then I would also suggest that this is the time when these individuals should not come to the hospital unnecessarily. I think teleconsultation, talking to your doctors over phone, whatever can be done without coming to the hospital should be done because after all, they're somewhat immunosuppressed. But in general, there is nothing to fear. After 2 to 3 months of transplant, you are as good as any other individual.
What about liver transplants? You said that, yes, of course, in cadaveric, the organ is precious. But is it even safe to undergo any transplant, a kidney or a liver transplant, during the time of the pandemic?
See, we have to understand there is a huge difference between kidney transplant and liver transplant. Kidney transplant people can easily survive on dialysis for a long, long time. So you have an alternate modality of treatment. So I would say kidney transplant, you have a good alternative of doing dialysis and waiting for a few months. There's no need to rush. But liver transplant, there's nothing which really can save if you are suffering from acute liver failure. So if somebody is acute liver failure or very advanced chronic liver disease, where the chance of survival is very low in the next few weeks or a couple of months, I think it is worth trying a transplant. But then, of course, the liver transplant cannot be taken lightly. All the healthcare workers who are involved must be either vaccinated or we should be sure they're not suffering from COVID. The contact should be very careful. We do not allow the family members to come in touch with them. So I would say that let's forget about kidney transplant. It's a different ballgame altogether. We can make them survive with dialysis for months to years. We should not rush into. For liver transplant, we should prioritize. And those who have very advanced disease, we should still do liver transplant, but with all precaution. At this moment, if you are doing from a diseased organ a liver transplant, we must be sure that the diseased organ is not, the person who is dying is not carrying COVID. Because if he's carrying the COVID, it may be risky.
Right. This brings us also to another question related to liver disease patients using public transportation and when they are on the move. Is it even advisable during this time? Or if they do, of course, now most states are in lockdown, so there is not much public transport. But if they really do need to travel during this pandemic situation, is it safe for them, like even to take a flight or a train or anything?
I think it all depends on what is the requirement and what are the means available. It is very easy for me to say that if you do not have a bread, have a cake. So I think you'll have to be realistic that if you need to go to the hospital, don't come out unnecessarily. I think if you have a pre-existing liver disease, you should not, whether there's a lockdown or there's no lockdown, if you have a pre-existing liver disease, don't go for a stroll outside your house or don't go for a picnic outside. I think only when there's essential to come out of the hospital, come out of your house, then only you should come out. If you have a means of avoiding public transportation, it's always is better. You can use a car or you can use a bike with only one person on the bike, or you're self-driving. I think it's best to avoid public transportation. And if you're using public transportation, please use N95 mask or at least 2 non-N95 masks when you are moving, because we are still learning. In the last pandemic, we were told that it's only the droplet which can cause the disease to be transmitted. Now we are talking about this being present in the air. So it can be an airborne disease as the new data is coming in. So I think understanding that these people, particularly with advanced liver disease, if they get COVID, there is a very high risk of mortality and morbidity. I think whatever can be avoided should be avoided. So I think vaccination, avoiding public transportation. If you have to use public transportation because of the economical reasons, please take as much of precautions as possible. Don't visit your doctor until it's required. Develop a rapport with your doctor so that you can contact the doctor through teleconsultation or on phone. This is the time when your relationship with your doctor will matter, and then doctor should be available to you.
What about alcohol intake, and how does that impact whether you have liver disease or not? Does it in any way make you more at risk, or once you get COVID, does it worsen the condition? And also post-COVID, there many people wonder whether it's all right for them to even take a drink socially. So what is your advice regarding alcohol intake during the pandemic?
I think if you look at the realistic scenario, and it's not true only for India, but overall a global scenario, the alcohol intake has increased during the pandemic. In fact, this is something which has gone, alcohol intake in general has increased. So I'm not going to say here that alcohol should not be taken, but those who have pre-existing liver disease, this is the time when they should avoid it. Alcohol may increase their liver disease, alcohol may reduce their immunity, alcohol may reduce their ability to fight with the COVID. So I would say that those who have pre-existing liver disease, this is the time to avoid alcohol. If somebody has alcoholic liver disease, of course, whether there is a COVID or non-COVID, they should avoid alcohol. For the general public, those who do not have a pre-existing liver disease, I would say if you are taking alcohol, take it in moderation, as any time I would talk about. But then I would not sit here and say that no alcohol intake should be there. That's wrong. But I think all the precaution, all the avoidance of excessive alcohol should be avoided. Those who have pre-existing liver disease should avoid. And the data suggests that those who have alcohol as an underlying cause of liver disease fare poorly as compared to those who have other causes of liver disease. So that's the relationship between alcohol, liver disease, and COVID.
Thank you, doctor. Is it possible to know whether our liver is in good condition? How to find out what kind of, this is more a general question regarding how do we make sure that our liver is healthy?
So, difficult question to answer. I would say that we have to understand that our liver is actually not one. There are 8 components of the liver. People often say that we have 2 kidneys, we have 2 lungs, but we have only 1 liver. Actually, we have 8 segments of liver which are looking together, and that's why we say that we have 1 liver. So we must understand that liver, we have a lot of reserve. Now, if somebody has only about 40% of his liver, he would still be healthy. So you may have a liver disease, and yet it may not manifest at all. So I think if you have to find out whether you have a liver disease or not, in absence of symptoms, only way is to do a regular health checkup, which should include an ultrasound and a liver function test. These 2 will generally pick up any liver disease in the early stage. I'm repeating, a liver function test, which includes enzyme, bilirubin, albumin level, and ultrasound. Now, if they do not pick up, then you are unlikely that you have a major liver disease. Of course, if you have manifestation of liver disease, which can be jaundice, swelling in the leg, swelling in the abdomen, blood vomiters, blood coming through the stool, all these can be symptoms of liver disease. But if you pick up liver disease, you must have a regular, at early stage, you must have a regular health checkup.
There's another question, the last question, but this not exactly to do with liver disease, but my son is 20 years old and he's autistic. And for the last couple of years, he's been having seizures. Can he be given a vaccine?
Of course, it should. I think there is, in fact, we in our hospital one day called all autistic children and we made them have the vaccine as a group. I think it is very important that these individuals are somehow immunocompromised. They may be on various medications, and so the risk is somewhat higher. If they get a COVID, managing them becomes even more difficult. So I think we have to prioritize as a society. These people must get the vaccine in time and must get the second dose also in time. So I think I would say a big yes to this answer.
So thank you, Dr. Goenka, for this wonderful and illuminating discussion. I'm sure that people with pre-existing liver disease are now much reassured that there is a way out, there are treatments available, but at the same time, they must be very cautious and alert when it comes to COVID-19. Thank you so much. And viewers, you can put more of your comments and questions in the Facebook page or send it to us through Facebook Messenger. So thank you. And till we meet tomorrow, please remain safe. Please follow all precautions related to COVID-19 by staying socially distanced, wearing a mask, and also sanitizing. Tomorrow, our topic would be a very interesting topic about are young people getting affected more during the second wave of the COVID-19 pandemic? The answer is being given to us by Dr. Sendur Nambi, consultant infectious disease specialist from Apollo Hospitals, Chennai. So see you tomorrow with all your questions. Until then, goodbye and namaste.